Hello. Hello. Hello.
Hello, you are
Ah,
audible, sir.
yes. Okay.
Hello, is this audible? Is it audible to everyone?
Yes, you are audible.
I guess we can start. It's time. So thank you for joining today's webinar on the scope of homeopathy in renal disorders. So we'll be starting it now. Good evening, respected doctors. I'm Dr. Kaushika, Secretary of IHMA Coimbatore chapter, and it gives me a great pleasure to welcome you all to our knowledge sharing series, Remedy for Malady 2.0. So today's session is focused on a very significant theme, that is scope of homeopathy in renal disorders. Before we begin, a small note to all the audience. If you have any doubts or during this session, kindly post them in the chat box. They will be addressed by the speaker during the question and answer session at the end of the sessions. So today's session is, as I said, is focused on the scope of homeopathy in renal disorders. And we are honored to have with us our distinguished speaker, Dr. Shenbaga Ganesh Babu, a renowned practitioner with over 25 years of rich clinical experience. He completed his BHMS from Father Mullah's Homeopathic Medical College, Mangalore, and persuaded his MD in repertory from JSDS Government Homeopathic Medical College, Hyderabad. Dr. Shenbaga Ganesh Babu has also been actively contributing to IHMA since 2012 and is also the founder state general secretary of IHMA Tamil Nadu chapter. His dedication, leadership, clinical expertise, and academic contributions make him a highly respected figure in our fraternity. I hope that today's session will bring new insights and practical understanding for all of us. On behalf of IHMA Coimbatore chapter, I extend a warm welcome to each and every one of you and to our speaker, Dr. Shenbaga Ganesh Babu sir. Sir, over to you.
Thank you, Dr. Kaushika. Am I visible?
Yes, sir.
Okay. Good evening, everyone. It's very happy and nice to see you all.
Good evening.
I am very much thankful for IHMA for giving me this opportunity to present in front of you all. And today we'll see about scope of homeopathy in renal disorders. I tribute to Dr. Samuel Hahnemann, because of whom we all are here, and he has given this divine science for us to treat the suffering people and to treat scientific way. My tribute to Dr. Praful Vijayakar, who has given us immense knowledge, and he has been a link between the modern science and miasms. Everything he has linked, and he has given new perspective, and he has given hope for treating even incurable cases which are left by other methods of treatment. Thank you very much, sir. The introduction to renal system. The renal system, also known as urinary system or urinary tract, is a vital homeostatic system in vertebrates. It encompasses the third kidney, bilateral ureters, the urinary bladder, and the terminal urethra. It is primarily responsible for the continuous regulation of chemical composition and volume of the plasma and extracellular fluid through the selective filtration of blood, followed by reabsorption and secretion in kidneys, culminating in the production and excretion of urine. And before we go to the proper disease proper, and we see about embryology, how the renal system is formed. The vertebrate kidney derives from intermediate mesoderm of urogenital ridge, a structure found along posterior wall of the abdomen in developing fetus. It develops in 3 successive stages known as pronephros, mesonephros, metanephros, and metanephros gives rise to definitive adult kidney. There's 3 stages of renal system development. Pronephros. Its development begins in the 4th week of gestational period. However, they will not form functioning kidneys in humans. Pronephric ducts develop in cervical region of the nephrogenic cord before extending and fusing with cloaca. Adjacent to pronephric ducts, intermediate mesoderm will condense to form non-functional nephron units known as pronephroi, which will regress by day 25. Mesonephros. Its development begins in end of 4th week to 8th week and in thoracic or lumbar region. It functions as a primitive excretory organ for short period of time. It degenerates in females. However, in males, the embryonic structure persists and develop into epididymis, vas deferens, seminal vesicles, and ejaculatory duct. And metanephros, its development begins in 5th week and it becomes functional around 12th week of gestation. Here you can see how each structure is formed from the metanephros. Formation of definitive kidney. The adult kidney is formed through process of reciprocal induction between 2 primary components. The collecting system. It is derived from the ureteric bud. Ureteric bud is an outgrowth of mesonephric duct. It grows cranially and penetrates the metanephric mesenchyme, undergoing series of branching events to form collecting system. The stalk of the bud forms the ureter. The cranial end that forms renal pelvis, which then branches repeatedly to form major calyces and collecting tubules or ducts. The excretory system derived from the metanephric mesenchyme. Metanephric mesenchyme, also the blastema, is a condensation of intermediate mesoderm. Signals from ureteric bud induce mesenchyme to differentiate into excretory nephron units through mesenchymal to epithelial transition. The mesenchyme cells form renal vesicles which elongate into S-shaped tubules. The proximal end of the S-shaped tubule is invaginated by capillaries to form glomerulus and Bowman's capsule. The rest of the tubule forms the proximal convoluted tubule, loop of Henle, and distal convoluted tubule. Kidney migration. The metanephros initially forms in pelvis. The lengthening of the caudal body part causes kidney to ascend to their final position in lumbar region. During this ascent, the kidney undergoes 90-degree medial rotation, causing the hilum to face medially instead of anteriorly. Development of bladder and urethra. The lower urinary tract develops from cloaca, the terminal expansion of hindgut. The urorectal septum divides the cloaca into rectum, that is the dorsal part, and urogenital sinus in the ventral part. The urogenital sinus primarily forms the urinary bladder and the majority of urethra. The trigone of bladder, a smooth triangular area, is formed by incorporation of terminal parts of the mesonephric ducts and the ureters into the posterior bladder wall. The renal system, its components and functions. The kidneys, it's a paired bean-shaped organs located in retroperitoneal space behind the peritoneum of abdomen, internally divided into outer cortex and inner medulla. Its primary function is it is a primary site of blood filtration and urine formation. The ureters, these are the muscular tubes that run from renal pelvis of each kidney to bladder. And constriction of ureter, there are three areas where it is constriction anatomically. One is the uretero-pelvic junction, and the second one is crossing the pelvic brim where ureter crosses over common iliac vessels. And the third one is uretrovesical junction where it enters the bladder. The function is transport urine from kidneys to the bladder through peristaltic veins. Urinary bladder, it is a hollow, muscular and expandable sac in pelvis. It stores the urine temporarily before elimination. And urethra, it is a tube extending from bladder to exterior of the body. It conducts urine out of the body. That is micturition. Nephron. Nephron is a microscopic functional unit within the kidney. There are millions of nephrons in the kidney, and it consists of renal corpuscle, that is a glomerulus and Bowman's capsule, and renal tubule, proximal and distal convoluted tubule, and loop of Henle. The function is it produces urine through three steps: filtration, reabsorption, and secretion. We see some of the renal disorders commonly what we see. The renal disorders categorized basically on disease course, that is the acute and chronic, and the part of the kidney affected. First is the kidney failure, that is acute and chronic. Acute is a sudden rapid decline in kidney function within hours or days, leading to the accumulation of waste products. It is often reversible. Its main features are oliguria, fluid retention, elevated blood urea nitrogen, and creatinine. And in the chronic, it is a progressive, irreversible loss of kidney function over months or years and progress through 5 stages. The causes of kidney failure are diabetes, especially high blood sugar. It damages the blood vessels and nephrons, that is diabetic nephropathy. Hypertension, increased pressure on blood vessels damages filtering urites, nephrosclerosis, and glomerulonephritis, inflammation of the glomeruli often caused by autoimmune or infections. Glomerular diseases. These are glomerulonephritis, inflammation and damage to glomeruli. It can be acute or chronic. Its main features are hematuria, proteinuria, hypertension, reduced glomerular filtration rate. Nephrotic syndrome, increased permeability of the glomerular basement membrane, leading to massive protein loss in urine. Its main features are massive proteinuria, that is more than 3.5 gram per dl, hypoalbuminemia, and generalized edema, hyperlipidemia. Nephritic syndrome, inflammation and damage to glomerular capillaries, leading to hematuria and reduced glomerular filtration rate. Its main features are hematuria, that is you see RBC casts or smoky urine, RBC cast in urine. Then hypertension, mild to moderate proteinuria. IgA nephropathy, it is also known as Burgess disease. It is an autoimmune kidney disease where deposits of immunoglobulin A antibodies build up in the glomeruli, leading to inflammation and kidney damage. Structural and obstructive disorders, that is a polycystic kidney disease, basically a genetic disorder characterized by growth of numerous fluid fields in the kidney. Its main features are enlarged kidneys, chronic flank pain, hypertension, progressive kidney failure. Kidney stones, also known as nephrolithiasis. Hard masses are calculi formed from crystallized minerals and salts in urine. Its main cause is high concentration of calcium oxalate, uric acid, or cysteine. Its main features are severe intermittent renal colic, which radiating from back to abdomen or growing, and hematuria. Pyelonephritis. It is a bacterial infection and inflammation of the kidney and renal pelvis. It is caused by ascending urinary tract infection, UTI, often caused by E. coli. Its main features are high fever, chills, nausea, severe flank pain. Hydronephrosis. This is the swelling of the kidney due to backflow of urine, due to obstruction, due to calculi. And it also can be due to enlarged prostate, tumors, etc. Its main features are flank pain, reduced urinary output. Here you get what all the features will be there in pre-renal and renal conditions, also post-renal conditions. There are the effects of pre-renal conditions, usually loss of renal function from hypoperfusion, and its effect on the other organs, that is shock syndrome of liver. Then renal, you get glomerular disorders, hematuria, proteinuria, edema, usually you see nephrotic syndrome, hypertension, loss of renal function. Then renal vasculature disorders are hypertension, loss of renal function. Interstitial disorders, usually leukocyturia, hematuria, proteinuria, less than glomerular disorders. Loss of renal function, especially tubular or medullary. And you get loin pain, example infection, pyelonephritis. Post-renal disorders like the problems with ureter, like usually you get symptoms of hematuria, loin pain, renal colic, ureteric colic. It can be due to calculus or due to tumors. And this also can lead to renal function, loss of renal function on the side of obstruction. Bladder, you get symptoms of hematuria and acute retention of urine due to obstruction. It may be, patient may be presenting with suprapubic pain or discomfort, oliguria, anuria, and incontinence and infection, cystitis. And urethra, you get, in penis, you may get erectile dysfunction, and urethra, hematuria, urinary retention, obstruction, and infection, urethritis. Prostate, you'll get prostatic prostatism, obstruction. You get hesitancy, dribbling, poor stream, frequency, increased frequency, urinary retention. Usually common investigation, what we do is laboratory investigations. In the blood, we check for urea, creatinine, and estimated GFR, that is glomerular filtration rate, and electrolytes. And urine analysis also will help to see whether there is a proteinuria and protein to creatinine ratio, urine albumin to creatinine ratio, urine culture also can be done, and 24-hour urine test. Imaging studies like ultrasonography and CT and MRI, also renal arteriography or venography also helpful in diagnosing the cases. And specialized and invasive procedures like renal biopsy, especially used for diagnosing the specific type of glomerular nephritis, that is IgA nephropathy, lupus nephritis, etc. It also helps in determining the cause of unexplained AKR, nephrotic syndrome. Urologic procedures, it is a cystoscopy, where the tube is inserted to the urethra to view the bladder and the urethral openings. It helps to identify lower urinary tract causes of obstruction or bleeding. And retrograde pyelography, is a contrast dye is injected to visualize the renal pelvis and ureters and help to confirm or locate an obstruction, especially stone or tumors. And miasm, actually, for homeopaths, miasm is very, very important, because Hahnemann has told that whether it is acute or chronic, we have to look for the miasm, and based on that, we can go for remedies which help in treating the patients. Usually in SORA, it represents the functional disturbances and inflammation. So conditions like cystitis, nephritis, urethritis, and urinary tract infections. In psychosis, it is characterized by proliferation, infiltration, and formation of excessive tissue or deposits. It's mainly associated with structural overgrowth and fluid retention. And conditions like kidney stones, cysts or tumor formation, polyps, benign tumors, this all comes under psychosis. And syphilis, it represents destructive and degenerative and deep-seated chronic changes. Conditions like end-stage kidney disease, necrosis of tissue, destructive lesions leading to chronic and non-healing ulcerations. Nephrotic syndrome, it is a psychosyphilitic condition, and also it can come under autoimmune. Autoimmune is purely, it will be syphilitic, actually. Based on the presentation, we are saying psychosyphilitic. In renal calculi cases, if it is without obstruction, it is psychotic. If it is with obstruction, hydroureteronephrosis, then it is leading to the destruction of the kidneys, kidney structures, then it is psychosyphilitic. Usually, conflicts. These conflicts means there will be some cause, basic cause will be there for each and every disease. So in what we say German New Medicine, that is GNM, they have formulated certain conflicts for the kidney diseases. Especially for kidney collecting tubules, there is feeling like fish out of water. It determines whether we are unexpectedly swept out of familiar surroundings or when we lose our pack. Conflict of kidney collecting tubules refers to an abandonment conflict, existence conflict, or refugee conflict. Abandonment conflict is brought on by feeling of being ousted, excluded, or unwanted, rejected, not understood, ignored, left out, isolated, and alone. Existent conflict, it is a fear for one's life, equal to fish out of water in danger of dying. It also relates to one's livelihood. The feeling behind conflict is, I have lost everything. Refugee conflict is experienced as being thrown into the desert, as if feeling uprooted or in exile. For example, unexpected transfer or move or being transferred. Unexpected transfer means somebody working in a job, government job or private job, and they're getting transferred to a far off place which they didn't expect. That also could cause some renal problems. Or move or being forced to flee from one's home or homeland. Kidney parenchyma, it is a water or fluid conflict. And water conflict, especially experienced with any accident in or on water, like burst water pipe, water leak, flooded home, sewage related problems. And fluid conflict refers to distress involving liquids. Example, harmful chemical substances, infusions or injections, etc. It also relates to body fluids such as urine, that is incontinence and semen, sexual abuse, unwanted sexual practices, amniotic fluid, water breaking during pregnancy or fluid discharge, that is vaginal discharge. Then conflicts related to renal pelvis and ureters, that is male territorial marking conflict or female marking conflict. Territorial marking conflict refers to an intrusion into one's place, that is home or property, including extended territory, neighborhood, village, city, country. You must have seen animals, usually they urinate. Why they urinate is they mark their territory and they wanted to say that this is mine. Don't come near or don't try to snatch from me. So same thing. Actually, it is usually this urinary territorial marking conflict comes for bladder related problems more common, and children experience this conflict at school, kindergarten, daycare, playground, also when new sibling is born, as because they have to share room with a family member or fight over a toy with a small child. They experience this, then they come up with recurrent UTI problems, and most of the time we have seen small children coming up frequently with UTI problems. And an occlusion of the renal calicus caused by a prolonged healing phase. The this is in the formation of kidney stone. Actually, in this, they say that even kidney stones are formed in the healing phase only. At one point, typically during the epileptoid crisis, that is a phase, healing phase, the stones are pushed to the neck of the calyx into the renal pelvis and further to the bladder. This process causes acute pain mainly because of the spasms and cramps in the inner wall of the renal pelvis. Bladder trigone. It is a ugly, dirty muscle conflict. That is dirty business and dirty tricks and dirty sex. Something which you feel it is very dirty. It is not actually dirty also. Sometimes you feel that it is dirty. Maybe like a delusion, like you feel strongly that it is dirty. Bladder mucosa and urethra. It is also that male territorial marking conflict or female marking conflict. And we go for the cases. Mr. J, 41 years old male, came with a complaint of pain in left loin since 2 days, vomiting 10 times since morning. Mild dysuria is there. Possibly he had bilateral renal calculi, took homeopathic treatment, and he passed the stone. That is around 2-3 years back, I think. Physical generals, he's thirsty, sleep is good, stool regular, bladder dysuria, and thermally is ambithermal, more towards chilly. And on 22/5/2023, we gave berberis 200 water dose every 1 hour, 1 spoon. Then on 23rd, he came in the morning. He told that he is having continuous vomiting, couldn't swallow even saliva, and he could not sleep, and pain in left loin extending to testis. So we changed the remedy. We given Diascoria 200 water dose every 20 minutes. At 1:15 p.m., no vomiting, but pain was there. So he told to continue 2 hourly. At the evening, he came again, vomited after going home, vomiting aggravation, eating aggravation, drinking water, nausea, aggravation, thinking of food, odor of powder, talcum powder, perfume. Is thirsty but vomiting after drinking, so he avoids. So we gave Naxomica 1 dose. Only 1 dose was given. Then next day, he came with no vomiting, but nausea was persisting, aggravation, odor of food. And we changed the remedy to Osimum canum because intense nausea was there. So 2 hourly, 1 cap was given. On 30th, he came back. He told pain in left loin again started. Nausea is present and thirstless is. Then we gave Tabacum 30 water dose 1 hourly. Then we sent for ultrasonogram because the nausea was very persistent. I was doubting what could be the reason. So we sent for ultrasonography and blood investigation. In that, he was having calculus measuring 9.8 mm. It was noted in the left proximal ureter, causing mild hydronephrosis. Then blood, you see, is having urea 64 and creatinine 4.1. So also he has acute infection. So total count all were elevated. So at this time, what we thought was he is going in for acute renal failure. That's why that severe nausea was there. So we took up the rubrics. Actually, when I was talking to him, he told that he was trying to get into politics, but because actually he's what to say, he sells vada in a small cart. So they are not giving much importance for him. So he felt that he is being is forsaken or left out, abandoned feeling like. So based on that, we took that rubric: forsaken feeling and stomach, nausea, food thinking of, kidneys complaints in general. So this is a repertory chart, and as the nausea was very severe, we thought of giving China 200 water dose. Only 3 times it was given. And remaining were only SL powders were given every 2 hours, 2 or 3 hours, every 3 hours. The next day he came, nausea was better, vomiting was better, appetite improved. So we continued with the SL, Nihilinum and SL, 3-hourly. Then he's actually, when he came on the first day, the lab where he took a report, I was not satisfied with the report. So actually, I sent him to another lab for checking. So there also the report was almost same, like urea and creatinine were raised, hemoglobin was normal. And so we continued with SL only because he was improving. So we continued with SL. But after 6, what happened? After 6 July 2023, what happened was I told him to repeat the investigation, but he didn't come only. So I was thinking like maybe he went for allopathic treatment or something like that. But what happened was after 15 days he came back. Then that time he took that investigations and came, and both urea, creatinine, everything has become normal. So he was very happy. Like even the lab fellow called me and asked, "How can you reverse this so easily, like within very short time?" Actually, when we repertorized the case, no, that time actually he was having severe nausea. Even he used to tell his wife, "Don't cook in the house." Like that, he used to say. He used to sit outside the house only, always. So nausea was very much marked in this patient. And this is case number 2. Steppy, 53 years old, male patient, had complaint of diabetes mellitus since 7 years, nausea since 3 weeks, aggravation site of food, aggravation eating while. Past history, he was having renal calculi and he was operated few years back. Then generals, thirsty, sleep disturbed on and off, stool regular, bladder regular, no perspiration. Thermally, he was.
Sorry, we are not able to see your screen share because maybe the points that you're mentioning on this of the repertorization, we are not able to see that. Can you share it, please?
Now it is able to see, sir.
No, we can see only Dr. Shrija there, but then you can just continue with your repertory chart on.
Yeah, this is a repertory chart I am showing now. Are you able to see now?
Kaushika and others, can
Yes,
you
sir.
see it?
Yes, sir. We are able to see.
Right. Okay.
Shall I continue?
Yes, sir. Yes, sir. Please.
Yeah. Sorry. Yeah.
And this is a case, I told the basic details. And this patient actually, he actually he was having raised urea and creatinine. So he went for the Madurai Kidney Center, which is a very renowned place. And they told that you have to go for a dialysis. So he became very much panicked and he doesn't want to take treatment. Then some of my previous patients, they told that you try this. So he came. When he came and he told everything, he was almost like very sad and he was crying only most of the time. So I could not get much detail. So that time they came very late also. So that time I took only nausea, sight of food and eating while aggravation. I referred and I gave pulsatilla 200. And they rang up in the evening. They told that he vomited and sent for the investigation. The urea was 57.9 and creatinine was 2.8. Hemoglobin was 10.1. Then next on 28th, again they came. Now I told to continue the same remedy, so we didn't initially change the remedy. Nausea was better, no vomiting, feeling mild imbalance in the morning, BP was normal, so we continued with the SL. And then 29, again, the 28th when they came, I told them to take investigation again. So they took the investigation and in that urea became normal and creatinine was almost, it was coming down and HB was little less. Actually, what I say is after I went into predictive methodology, like Sar used to say, when you treat renal cases, actually first to improve should be hemoglobin. Then creatinine should come down. Then hemoglobin should improve, creatinine should come down, and then urea should come down. So that is the like hierarchy of how we should assess the improvement. But in this patient, actually, hemoglobin was less. But thing is that in laboratory reports, we cannot say anything because the same day you check in a different lab, you are getting different results. So I didn't take it up very seriously that time. Then again on 31/12 we checked the urea. It was 49, creatinine was 1.78, hemoglobin was further less, and ultrasonography showed two 6 mm calculi in the lower calyx. Kidney showed mild increase in cortical echogenicity. So based on the history, I gave lycopodium 200 one dose and continued with SL. Then 14/1, after 15 days, they gave no nausea, no imbalance, and BP was normal. So SL continued. Then again, after 2 months, we took urea was raised, but hemoglobin was improving and creatinine also was coming down. Blood sugar was okay, below 200 it was, and uric acid was raised actually. So again, SL only we gave. Then on 24/3, again investigation was done. Urea was 47, creatinine 1.8, HB was increasing. So I didn't mind about this creatinine and urea, slight fluctuation is there. Uric acid became normal. So again SL I gave. Then on from 11/4 to 25/6, he didn't have any complaints. So only we gave SL only. And this patient, every 3 months now also we check for urea, creatinine and hemoglobin, and mostly it is within the normal limits only. Creatinine used to be 1.2, 1.3 maximum, and urea creatinine and urea is always below 40, and hemoglobin is good, more than 12 or 13 it is. He was happy that he didn't go for dialysis, and like after he came, nearly most of his family members, they come for each and every illness. They have good faith, and they also referred a few other patients with urea and creatinine increase. This renal failure patients. This is case number 3. Mrs. U, 25 years old female, came with a complaint of pain in left loin since 3 weeks. Pain radiates from left loin to abdomen. Loin pain is aggravation mostly in the night, constant dull pain, aggravation daytime, aggravation turning in bed. Nausea, appetite is diminished, feverish feeling. Past history, measles at 8 years of age, chickenpox 9 years, and abscess near left elbow 12 years, tonsillectomy 16 years of age, UTI 18 years of age. Family history, mother had ringworm, eczema, and acid peptic disease. Father had renal calculi. Physical generals, appetite is diminished. She feels thirsty, stool regular, bladder regular, cannot tolerate as usually, but no incontinence on coughing or sneezing. Perspiration, more in the forehead, mild odor, no salt deposits, no stain. Sleep is good. Thermally hot she is, and sensitive to sun exposure causes headache. Perspiration leads to headache. Profuse perspiration, if you perspire, then you get headache. Sensitive to flowers, the odors causes headache. Sensitive to noise, sensitive to tight clothes, mainly around neck, it makes uncomfortable. On 22/4/2020, ultrasound was done, and it showed a pelvic calcium system and upper ureter mildly dilated, a calculus of 4.7 mm noted in the left upper ureter, just below the pelvic junction. So we gave Naxomica 1 mm and with flying pills. On 10, she came, pain increased, and even jarring, mild jerk also causes more pain, nausea, stool not passed, pain in left upper chest. I think that time only that COVID was prevalent. So we had a doubt actually whether she is also having COVID-like illness. But in spite of that, we gave belladonna 1 and sent because all the scan centers were very busy. So we could not send immediately. Then on 11/5, they somehow tried to and took ultrasonogram, and the left kidney appears swollen with compression of renal sinus, extensive perinephric fat standing, and minimal perinephric fluid collection is seen. And it's acute pyelonephritis, minimal free fluid in pelvis, and pelvic calyceal system and upper ureter mildly dilated. She had mild temperature, but during COVID time, even if it is just above 99 also, we consider it is fever only, because the normal time, if there is a evening rise of temperature of 1 degree also, we don't consider only. But during COVID, even slight increase also we consider. So based on the symptoms she presented with and the pathology, I gave Mercor 200 one dose and SL. On 12/5, the hemoglobin was 10.4, total count was 15,000, and polymorphs are increased, and ESR was 60 mm in 1 hour. Urea and creatinine were within normal limits. She had trace albumin in urine and also deposits 5 to 8 epithelial cells. So temperature was the next day temperature was normal, but chills were present. She feels heat sensation on and off, and stool passed. She felt thirsty, but had a strong bitter taste. So again we worked out. Then we took the rubrics: kidneys inflammation, pylon, kidneys complaints in general, taste bitter, chill during. So I was at this time I was having a dilemma whether to give China or China Arts. Then I chose China Arts because the chills and the sensitivity of the pain and everything. So because of that, China was chosen, and only 1 dose was given, and remaining SL powders 2 hourly. On 13/5, she had fever and pain in left loin is better, but still had pain while turning in bed. Stool passed, urine yellowish. She had a rumbling in abdomen and bitter taste. So I thought, okay, fever has come, so maybe it has not worked. So went for China Sulf now, 1 dose. So I told her that time we took the X-ray also, we checked it because we had a doubt whether she has any pneumonia, but nothing was there. And on 15th, we did an ultrasound, a CT scan abdomen. In that, it came as there is like urine collection in the kidney, and it is swollen, so it may be like urinoma they had mentioned. So you can see here the calculus and hydroureteronephrosis. So they gave us left acute pyelonephritis, scapular and perinephric collection, that is urinoma, secondary to ureteric calculus obstruction. So on 15/5, she was telling that still not able to turn in bed comfortably. Bitter taste is slightly better, but still there. So we again changed to China. The next day she came up with 103 fever. So we had a dilemma whether we are going in the right direction. So she had a headache also. So again gave Mercor 1 dose. Temperature became normal, but bitter taste was very prominent. Like everything tastes bitter, even saliva and water. And she had sleeplessness. So even the generals, what we consider it is not become normal. So I continued with again China. I thought maybe few more doses are needed that we didn't give. So again China was given. On 18/5, she told bitter taste has reduced and pain in left loin slightly better. So now she could lie little bit better. So continued with China. Then 19, temperature became normal and appetite is improved, but bitter taste she is slightly there. So and she is not willing to eat. Pain in left loin also decreased. So continued with China. On 20th again they came. Pain in left loin better, bitter taste decreased. Then we gave SL only. After that, she got married and she left to Chennai. She didn't come for a very long time. Again, when she came after 1 year or something, she was having a scan which showed that everything was normal. Unfortunately, we couldn't record that, keep that scan report. And case 4, this is Mrs. M, 19 years old male patient. Mr. M, 19 years old male patient, had complaint of pain in both loins since 6 months, increased since 10 days. Pain extended to abdomen, both lumbar quadrant of abdomen. Initially started in right side, then to left side. Intermittent pain, aggravation, sweets, fish, mutton, sitting, aggravation, better by lying on back, better after urination. Had dysuria, burning pain, aggravation while and after urination. Past history of renal calculi right side, 2023, passed the stone. And appetite diminished, thirst 1.5 liter per day, stool regular, bladder dysuria, perspiration, general, scalp, face, neck, sleep disturbed, thermally is ambithermal. And this is his scan report. It shows left hydroureter nephrosis, calculus of 6.4 mm, another calculus of 11.3 mm noted in the left vesico-ureteric junction. Then, at that time, we gave Berberis vulgaris 200 water dose 4 times and continued with blank tablets and pills, plain pills. On 210, he came back. Pain in loin better, passed stone few days back, feeling mild discomfort in lower abdomen, aggravation sweets. So then we took the symptoms like urine sediment, gravel, small calculi, generalities, food and drink, sweets, aggravation, generalities side, right, then left. Because initially he had a right-sided calculi, now he's having left-sided. So we took that rubric also. And we gave lycopodium 1 dose on 210. And in 1910, he came with a mild, he told complaint of mild right loin pain, dull pain, no dysuria, urine flow is good. So continued with lycopodium. On 911, he told occasionally he gets pain actually, better than before. So again, 1 dose of lycopodium and SL were continued. On 2911, there is no pain. And again, SL was continued, lycopodium was continued. Then, and he came with 8-1, he took the scan and came. And in that, you can see only 1 mm upper lobe stone is there in left kidney. Other calculi are not seen. This what I want to say is usually some patient passes calculi totally, but some patients they don't feel they passed. But if you take scan and see, calculi won't be there. Actually, calculi should not be passed as such. Calculi, how it is forming, same way it should get dissolved and it should come out. That is the right way actually. So no complaints. Lycopodium 1 dose was given, and after that he didn't come for treatment. This is case number 5, 39-year-old male patient, renal calculus since 3 years, and he took treatment for a few months. Now initially right side, then also left side. Presenting complaint, he came with the complaint of scanty urine and hematuria since 1 day. Dysuria while urination, had irresistible urge for urination, right loin pain, has uneasiness and mild headache, thirst increase, stool regular, thermally hot. And USG abdomen, gross dilatation of pelvic calyceal system, upper and mild mid-ureter noted, calculus of 11.6 mm seen in right lower ureter. So the scan was taken on 5. So we came to the consultant. That time we gave lycopodium 1 mg 1 dose, and remaining SL and pills, plain pills were given. On 27/9 he came, no pain, no hematuria, no dysuria, but had irritation, aggravation while urination. We continued with the SL. And this is a scan which he had taken in 2023. That is 17.4 mm calculi. So this is 2013, and this is now again he has come with the calculi in 2023. See, this calculus was very huge, and he went for allopathic treatment initially. Then he came to me. Then on 4/9/2023, he told that dysuria since 2 weeks, frequent urination, pain in right lower abdomen since 3 days. He had constant urge to pass urine and stool. So based on this symptom, that is constant urge to pass urine and right-sided calculi, we gave Naxomica 0/1 200 ml water dose, 1 cap 4 hourly. And that day evening he called me. He told that pain is still more and he's feeling pain in the urethra. I told him he continue the medicine every 15 minutes. So that day, I think that day night or next day morning, he passed the stone. Then he only took the stone for analysis. And this is the report which he brought after the stone analysis. And this is a stone which he passed. See the size, it is almost 1.5 centimeters. And he told dull pain in the urethra. So SL was given. For some patients, like after passing the stone, no, they will have irritation and some uneasiness in the urethra and bladder. So at that time, we can give arnica. We can think about that because of injury from calculus. Is another case. This patient had pain in loins since 6 months, increased since 2 days, aggravation sitting continuously, dysuria, burning pain in urethra, better after urination, had severe pain twice within 6 months, dribbling of urine since 10 days. So his appetite is good, thirst 2.5 liters, stool regular, bladder dysuria. He could not tolerate urge. He has to pass immediately. Perspiration increased generally. Sleep is good. Thermally is hot. And CT scan previously what he brought, it was showing 4x4 mm calculi, 1/6 mm calculi in left upper part of the ureter. So left side ureter, so we gave initially Berberis vulgaris only because the symptoms are covering, and we continued with SL. Only 1 dose was given, and the next day and after 10 days he came, no pain, burning micturition better, but still mild irritation is there. Then we gave lycopodium 200 1 dose. Lycopodium, it comes for even right-sided ureteric colic as well as left-sided ureteric colic. Berberis also, both sides you can think of. Only certain minute symptoms we can differentiate, like radiation of pain, some other specific symptoms. Lycopodium, if with acute pain, they'll be very much rolling. They'll be crying and weeping. They'll be rolling on the floor, shrieking will be there. Not all patients, but it will be there. If you can check with the repertories, it will be there. Then on 22/6, mild left loin pain, urine flow slow. So we gave Cantharis 1 dose. Then in 27, no pain, urine flow was normal. So SL was given. Then 28/9, mild pain in left loin since 2 days. Again, Berberis 1 dose was given and continued with the SL for 15 days. On 18/1/2013, he came with the scan, 7 mm intrarenal calculi in left kidney, no calculi in urethra or bladder. So again, Berberis 1 dose was given. Then 13/4/2013, no complaints. We continue with the SL. Again, in July 31, 2013 also, didn't have any complaint. We continued. And ultrasound showed, did not show any abnormality. That time ultrasound he had taken in 2014. It was normal, no abnormalities were detected. And we have some, I think it is taking, will take very long time. So commonly we use these drugs, Berberis vulgaris, Lycopodium, Cantharis. These all drugs we use for especially calculi and urinary tract infections. And you get, you know from Medica, the characteristics of each remedies. So according to that, you can go. Diascoria we used in one case. So because of that, we have put up this with pain in extremities, colic better by walking, bending backwards. Yeah, this was that patient, bending backwards. The first case. Corrosivus, it is intense burning, albuminuria. And this corrosivus, it is very much indicated in pyelonephritis and in infections of kidneys. And Naxomica, you know, it is a ureteric or calculi with frequent urge for urine and stool. Belladonna, you can think about in when there is severe tendinitis and scanty urine and pain aggravation from jarring. Even in some cases of calculi which get obstruction, I have seen some doctors using belladonna in high potency for causing dilatation of the ureter. Some, I think one of my teacher, he used to use even belladonna, mother teacher. And cannabis sativa, the zigzag pain along the urethra, epismel, have the burning and loaded with the cast and frequent involuntary micturition. This also is indicated in kidney infections and also ureteric calculus pain. And tabacum also renal colic with cold sweat, nausea. Nausea will be very prominent in tabacum. And we have paralysis of sphincters and dribbling of urine. I'm skipping a little bit because the time is time is getting over. So general management, what usually we say is dietary lifestyle modification, dietary changes, and limit sodium and potassium and phosphorus intake, regular physical activity, maintaining healthy weight and quit smoking, limit or avoid alcohol and tobacco products. And for medical management, we have to manage the high blood pressure with medication and lifestyle changes and control the high sugar level, manage complications like anemia and control mineral levels. And usually in our clinic, what we used to say is during the acute episode, take plenty of fluids and don't hold the urine for a long time. You take tender coconut, but most of the people, some people, they take in empty stomach tender coconut. But what I feel is you have to take in the midday, like you have breakfast around 9 o'clock, then you take around 11:30. And you should advise the patient after taking tender coconut, you should pass urine in 1 hour because that is usually capable of clearing the lot of debris and everything from the kidneys. And here many in our place they use lot of local remedies like that plantain stem juice. Then one more is the Yanai Nerinch. Then one more is Kanupulechidi. So these things they use for dissolving the stone. But actually, plantain stem juice, if it is taken in excess, it will cause person may feel very cold, and is capable of causing some nervous disorders, it seems. So usually I tell the patient, if you want to take, you take very little. That is around 30 ml once in 4 days or 5 days. Little more only you take. Don't take regularly. And moreover, why I tell them not to take the native remedies is because in that also some individualization should be there for whom which is suitable. Then only it will act. Simply just taking because everyone are telling. And many people used to take as soon as they find some disease with the kidney disease, they take lot of radish, and radish radish curry or juice, everything they start taking. And each one will tell one ideas, and people will won't tell us also sometimes. Sometimes we don't know what will happen in between, because some people will be improving and suddenly you get and then if you inquire, they will tell that I started taking this from this many days, like that. So we have to always keep inquiring about what happens. Like then only we'll come to know. And also I used to advise them take one carrot daily, and also this horse gram is there, no? We can roast it and we can make it into powder daily morning, 1/4 teaspoon in warm water. That also helps in cleansing the kidneys, they say. So for some patients, I advise that. And during the acute episode and with the pain, they give in allopathy, they give drips, IV fluids they put for pushing the stone. In here we use actually this barley rice ganji. That is also, it will cause a lot of it will produce a lot of urine, and it will push the calculi. And the learning session is individualize the patient, treat the man in disease and not the disease in man. Try to find out the PQRS symptoms. Try to find out probable cause. In these cases, actually, I may have not shown some like details about the case history, because due to lack of time, and moreover, some patients, no, they will come with severe pain and they don't give the entire history. They want to just get rid of. And in those type of severe pain, what we used to do is we used to make them sit or lie down, and we give the medicine in olfaction, and it gives wonderful result. Olfaction every 10 minutes or 15 minutes also we give, and the pain is relieved. If olfaction we can give, or water dose. Actually, why we most of the time we give in water dose is, Hahnemann has told in aphorism 247 that if you the right remedy, if it is put in sugar of milk and crushed and dissolved in water and give, and each time the dose should be like slightly altered and given the higher potency, then it will act better and the patient will be relieved fast. So based on that, I now mostly give water dose only for all the cases. And mostly we give single remedy with minimum repetition. That works wonders actually. If we give 50 millisiemen potency, then we are giving very frequent repetitions and continuously. If we go for centesimal potency, depending upon the case, we can decide the repetitions. That I cannot give for each and tell for each and every case. You will understand when you during your practice, you will by experience you will come to know that how to adjust the dosage and assess the patients. Most of the cases which I have shown, I have given mostly single dosage, single dose only, and didn't repeat only. But in few cases, I have repeated the medicines, and also that also has given good results, because due to the severity of the symptoms, we have repeated. Thank you for listening to me, and hope you must have understood. I thank IHMA Coimbatore chapter for giving me this opportunity, and I thank each one of you, Dr. Dheeraj, Dr. Bindu, Dr. Kaushika, Dr. Mugila for arranging this. Dr. Jagadi also, she helped in arranging for the presentation. I thank my junior doctor, Dr. Lalita. She helped me immensely in preparing this slides, and all this helped me in this work. And I thank you one and all. And dare to be wise. Thank you.
Thank you, sir. Thank you for the insightful session. With your permission, we have a question. Shall we move on to the question and answer session,
Yeah,
sir?
sure.
A doctor asked about, can you please repeat the reversal hierarchy in renal pathologies?
I didn't get you.
Am I audible, sir?
Yeah, repeat the reversal hierarchy.
Reversal hierarchies in renal pathologies. You have mentioned about hemoglobin, creatinine,
yes,
and
yes.
urea, no, sir?
Yeah.
Yeah.
That is actually, if you see like hemoglobin, actually, it is more vital. Actually, hemoglobin is also synthesized based on the health of the kidney only. So what Professor used to say is hemoglobin should never come down. Like if urea and creatinine is coming down, it is coming down, but hemoglobin is going down means it is wrong direction of cure. Whenever you treat like renal failure cases, when urea and creatinine are coming down, hemoglobin should increase from, if it is less, like if it is previously 7 or 8, it should improve 9, 10, like that it should come. Then the next is creatinine. Creatinine should come down. Urea is not much important than creatinine. So urea is the last one. It should come. Means sometimes both will come down. If in case urea is more also, you need not bother. If creatinine is coming down and hemoglobin is coming, it is rising, then you need not bother about the urea. It will come down within few days. Okay.
Okay, sir. Okay. Okay, sir. Dear
Niglinum is
participants,
nothing.
do you have
Actually,
any questions?
Actually, somebody has asked what is niglinum. Niglinum is nothing but the name what we are given for SL powders in our clinic. We used to give name like Plabo, Niglinum, then Lago 200, like that we are given some names, Cortana.
Okay, sir. Dear participants, do you have any questions? Please put on the chat box or please raise your hand and unmute yourself.
See,
So Dr. Mukila
always,
asked.
I saw that question. Dr.
Yeah,
Mukila,
okay, sir. Okay, sir.
Yeah, ourselves stood first, but the patient I told no, he was having some like severe disgust for food, and the pain also was the pain was severe and he was sensitive. He was like very irritable with his wife. Like he was sitting outside the house and he used to tell, "Don't cook. I am having severe nausea." The severe nausea we considered, and because of that, China we gave.
Any other queries? Dear doctors, do you have any other queries?
What do you mean by therapeutic prescription? Can you explain what you wanted to ask?
So they are asking about specifics, it seems.
Specifics. Usually, don't give specifics. Thing is that when we are busy in the OP and patient is suffering with pain, then we think about like if it is mostly ureteric calculi and it is a left side pain radiating to thighs or lower abdomen, testes like that, and patient is having nausea, then we usually give berberis for left side. Even if it is for right side, mostly if the patient presenting with ineffectual urge for urine and stool, and he is very irritable, that all we consider and we give Naxvomica. Sometimes only in acute phase, lycopodium I have given only in few cases like in acute phase. Mostly after the initial prescription only we have continued with lycopodium in most of the cases. And in some cases we are used to Diascoria also. The Diascoria I told no, pain will be like better by bending back and extending to the testicles, I think. These both will be there. And depending upon the sites and other things, we can differentiate. And one other remedy is Cantharis also we can use. like if the pain is like cutting pain and pain is having severe burning pain means, then we can use Cantharis. Aphorism 247, Hanuman has mentioned about how we have to give the remedies. Like, don't know whether I'll be able to put that. No, you can see in aphorism 247. Yeah, what Hanuman says is if the medicine selected with the utmost care was perfectly homeopathic, secondly, if it is a highly potentized, dissolved in water and given in proper small dose, that experience has taught us the most suitable in definite intervals for the quickest accomplishment of the cure, but with the precaution that the degree of every dose deviates somewhat from the preceding and following, in order that the vital principle which is to be altered to a similar medicinal disease be not aroused to untoward reaction and revolt, as is always the case. He's talking about medicinal aggravation also, and also he is telling that for getting faster relief, we have to give in water dose. And he has told in the footnote of that aphorism, like that footnote is 132. He has told that he has updated at that time. He has come to in the 6th edition. During the 6th edition, he has invented that 50 millisieverts potency. So what he has done is that time he has mentioned here the new perfected method will solve all the problems he has mentioned. Patient with pyelonephritis is severe chorea with personal. Patient is diabetic too. Kindly guide what medicine can be given. So, Dr. Vinodini, actually, if you send me the details of the case, other than these are common symptoms. With this, I cannot suggest the remedy. If I can get more generals like physicals and generals and something about the patient, then it will be easy. Pyelonephritis, you can refer, like one more thing I wanted to say. You can refer in under kidney section. You have a lot of rubrics related to this kidney diseases like inflammation, pylon is there. You can check with that in that. And in urine chapter, under sediments, you have casts and other things are there. And even red blood cells, everything is mentioned in there. And even in a complete repertory, even stone is also gravel, like that it is mentioned in urine chapter only under sediments rubric. Sir, any useful mother tinctures to catalyst cure? No, I don't use mother tinctures. Usually they say like what to say, hydrangea mother tincture. Some say that it is helpful, but I have not used it. Water intake, actually in renal failure cases, we cannot tell them to take more water. But in normally in kidney problems, if the patient taking very less water, like only 1 liter they take, something like that, then if it is summer, you tell them to take 3.5 to 4 liters of water. Then you advise them to reduce the non-veg actually, because you should not give very much stress to the kidney, because sometimes if you take they take excessive non-veg in the night, they try to get in the get pain in they may get pain in the night. Actually, in the midnight they may get pain. renal calculi, it is not time duration. If your remedy is right, I showed in one case, no, if our remedy is matching with the like a situation or the person exactly, you see 17 mm stone, he passed the next day. So like that, miracle can happen. Sometimes some patients, most of the patients, I have so many cases actually, because one allopathy is there near to me. He does ultrasound regularly, and weekly minimum 4 to 5 cases of renal calculi he used to send me. So most of the cases, problem is that either patient doesn't continue, or they doesn't come immediately, and they come after a few years. They say that I was better that time. You give me remedies, like that they say. So we don't have that proper report. So I could not like tell, because some cases even after one course of medicine, like usually what he does is, he usually give if when the patient come with acute pain, he gives injection and gives some painkiller tablets, and he will tell them, he'll take scan and send them to me. He will tell them that you go and take medicine from that, sir. He will give medicine for dissolving the stone, and for preventing the recurrence also. So what happens is, some patients they sincerely they continue and regularly they check the scan. But some people when they come, they become all right with the first initial medicine. They just discontinue, or they doesn't turn up. So because of that, like a lot of cases, we are not having the like after treatment reports. We didn't have. That's why we selected very little cases only. And one patient and all, in 2007 or in 2009 or 10, I think, I treated for renal calculi. He is actually some 20 kilometers away from my place, and till now he is sending regularly calculi patients to me. Renal pathologies, when to refer is, if we are not able to give like even in chronic renal main, you can treat, like provided you should individualize the patient, and in minute things also you should observe sometimes, because in these two cases what I have given medicine, we have shown improvement. They actually improved very well. They even I didn't expect that first case. No, even I didn't expect, because I was very anxious that till the prescription, last prescription. After that 15 days he didn't turn up. I was in a mood that mindset that okay, he must went gone for allopathic treatment. But after that he came back and he was very happy. So reference is up to you. If it is if the creatinine and urea is very too much high, then also we should find actually the what is the basic cause. I have given you the conflicts related to kidney diseases, and you try to get from like get the basic details in what like situation, how they felt, how they reacted, what thought of mindset they were in. So everything we have to inquire, and based on that we can arrive at the remedy. And always you take the don't take too many symptoms, and don't take common symptoms. Only take what is important for the case. Usually egg and milk and all non-veg, many doctors tell to avoid, even cabbage, tomato and cauliflower. But usually in my patients, I never tell them to stop anything. But what I used to say is, if tomato is there in the curry, let it be there. You don't take and eat separately, and don't eat anything which aggravates you. And if it is aggravation, you timing you stop. Then after the treatment, you should be able to take. That is that only I used to tell to my patients. I don't know. Say sincerely, what I say is initially when during my initial stages of practice, I used to use lower potencies, frequent repetition, and sometimes 2 remedies also I have given. But slowly I have stopped that because I was feeling little like we should not do that. We are a qualified person and we have studied for so many years. We should try to stick to the basic principles. So actually what happened was in 2004, I think, one seminar we went and we learned about lot of mother tinctures. I ordered so much of mother tinctures and nearly for 25,000 I brought mother tinctures. But when in 2005, I think I totally changed to this single remedy and minimum dosage. When I changed, I didn't, till now I have not used it. My dad used to scold me. He's also homeopath. He was also, yeah. So he used to scold me, why you bought all this and I kept like this, like that. He used to scold me, but I didn't mind because what I used to feel is, okay, we try to give better care for the patient. We should not suppress. If you are not able to cure also, we should not suppress our patient's condition because every time you suppress, it will keep on going from one level to other level. So it should not happen. Even in that pyelonephritis case also, that patient didn't come for the regular follow-ups. So in between, she was not coming very, very long time. And then after she became worse with pyelonephritis only, she came back. Because most of the patients, what they do is when they come to the treatment, they go to each and every hospital and last they will think that, okay, we'll try. Or some of the relative told, you try this also for some time. Like that they come. And mostly like some people, they fear for this surgery, cost of the surgery, all these things. And so because of that, they come for this thing. There are key points of terebinth, oxalic acid, pereira. See, this you can get it from Veterinary Medica books, no? That will be very better, I feel. Because I have used, as you I have asked, no, terebinth, pereira, brava and all I have used, but right now I have not have the ready, like I have not made the slides ready for that remedies. So if possible, I will share later. Okay, if I get an opportunity, I will share later about that. Because in most of the cases, not only like berberries or lyco, we have given different remedies and we have got wonderful results also. Thing is that we don't have supportive evidence or the case material is not proper, so we could not share those cases actually. You explore with the rubrics from repertories, especially complete repertory or synthesis repertory. These repertories will give you like wonderful rubrics will be there. Like you can take one rubric from one pathological rubric and in general, like complaints of kidneys in general, and one rubric from which is very PQRS from the patient we can take, and with the help of that we can arrive at the remedy very easily and differentiate it based on the intensity of the symptoms. And even sometimes we need to see the thermal state also. How much fees when giving single medicine, minimum dose? That depends upon what to say, even the socio-economic status of the patient also, because not all the patient we can charge. Now we give like for 15 days medicine we give means we are charging around some 500 or 600 something like that. Not for one dosage, we give 15 days medicine. Like medicine may be given in one dose or given in the water dose like 200 ml or 100 ml bottle we give, and we advise them to take according to that. Like you read in Organon, you read how Hahnemann has told about how to dispense the medicines, especially 50 millisecond potency. It is given in the footnote. So you read that and you will understand. But one time if you read, you won't understand. Repeatedly you have to read. And it will be given in, I think, in different measurements, teaspoon, tablespoon, like that. So you go into Google and search how much is 1 tablespoon, how much is 1 teaspoon, and according to that you make the medicine ready and you prescribe for the patient. And every time you give, you tell them to succus and show them how to succus the medicine. And I usually give in 200 ml or 100 ml PET bottle, and in that, especially like a half cap or 1 cap, depending upon the situation I give. There is no fixed criteria, like only by your experience you will come to know how we can alter the dosage and everything. And if you don't get the desired result, you have to stop the medicine and you have to change over to more suitable remedy. We have to fix in mind about that also, because when we repertorize, that time itself we'll find out what all remedies are coming. Even without repetition also, sometimes we have to think about remedies immediately. So for that, you have to keep reading your Materia Medica and keep referring the repertory, especially these chapters like kidneys, bladder, urethra, these chapters. You go through the rubrics when you are free, and you will get wonderful rubrics which you can use. Because whenever we go through minute rubrics and smaller rubrics and everything, we can use it in different cases, and we can share the knowledge with our friends and other juniors, everybody, so that they will also get benefited. Not only that, you can use Dr. This one, NER repertory. It is there in Homeo International website. It is there. NER repertory also has very good rubrics and remedies mentioned against that. And in some cases, you can use bogus synaptic key, then Pathak's repertory. It gives wonderful remedies which may not be mentioned in the different repertories. So you go through that. And Lilienthal's therapeutics are also very good. You can go through that. Okay, then we'll finish.
Thank you, sir. On behalf of IHMA Coimbatore chapter, I sincerely thank our speaker, Dr. Shenba Ganesh Babu, for the insightful talk on the scope of homeopathic remedies in renal disorders with case reports. Also, I'll appreciate your patience in answering these questions. And my special thanks to our host, Dr. Jagati, for smooth technical support, and Dr. Kaushika, Secretary IHMA Coimbatore chapter, who co-hosted and guided this session with dedication. Most important, I thank all participants for your invaluable time, interest, and active involvement, which made this webinar truly meaningful. As we conclude, I wish each one of you and your families a happy and blessed Puja festival filled with health and prosperity. Thank you, sir. Good night, all.